Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the lower limb anatomy, and this is an USMLE review. By the end of the session, the students should be able to understand organization of the lower limb, master lumbar and sacral plexuses, clinically identify major nerves, vessels, and muscle group, apply high-yield clinical correlation, and will solve multiple choice questions. Those are NB-ME type. Let's start. Okay, so regions, we have to give emphasis on all the regions of the lower limb, like gluteal region, thigh, leg, foot, bones, hip bone, ilium, ischium, pubis. These three component together forms the hip bone, femur, patella, tibia and fibula, tarsals, metatarsal and phalanges. Okay, this forms the foot. Tibia fibula forms the leg. Tibia transmits body weight, and it is also site of origin of muscles. Fibula, tibia is also site of insertion of a muscle like popliteus. Fibula, site of origin of muscle, insertion of muscle. Okay, so we got that. Now here we are looking inside the abdomen. In the posterior abdominal wall, we are seeing the lumbar plexus contributed by T12, like that of subcostal nerve, ilioinguinal nerve, iliohypogastric nerve, root value L1, both of them. Subcostal root value is T12. We are also looking here the genitofemoral nerve that pierces the psoas major muscle. It is two part. One is the genital part, another is the femoral part, and its root value is L1, L2. This is psoas major muscle. This is psoas minor muscle. Then we are looking for the other nerves like lateral cutaneous nerve of the thigh, root value L2, L3. It pick up sensation from this side, and it may be compressed here under the inguinal ligament or around the inguinal ligament. So in that situation, there will be burning and pain sensation on the lateral aspect of the thigh, and clinical condition is called myalgia paresthetica. So due to compression of the lateral cutaneous nerve of the thigh. Lumbosacral trunk is a communication between the lumbar plexus and sacral plexus. It is formed by L4, L5. And we have the femoral nerve. Femoral nerve is a very important nerve. Innervates all the muscles of the front of the thigh. It has also cutaneous branches. And femoral nerve root value is L2, L3, L4. We have another nerve, that is the obturator nerve. Here is the obturator nerve, again root value L2, L3, L4. Okay. Here is the cutaneous branches of the femoral nerve here, cutaneous branches of femoral nerve, cutaneous branches of the obturator nerve. And we are also seeing the area of distribution of the iliohypogastric ilioinguinal nerve in this area. Okay. So this is the area, cutaneous sensation carried by the femoral nerve, this area by the obturator nerve, this area by the lateral cutaneous nerve of the lateral cutaneous nerve of the femur, okay, or thigh. We got that. This is the lateral cutaneous nerve of the thigh, root value L2, L3. So if we go to the sacral plexus, then our root value again lumbosacral trunk is contributing L4, L5, and we're getting multiple nerve like that of the Supragluteal nerve supplying the muscle like that of the gluteus medius, gluteus minimus, and the tensor fascia lata. Infragluteal nerve innervates the gluteus maximus muscle, nerve to the piriformis. Okay, yeah. And pelvic splanchnic nerve is preganglionic parasympathetic nerve from S2. It is also getting contribution from S3 and S4. And this is the sciatic nerve, which is a very big nerve and very thick also, and it is getting contribution from L4, L5, S1, S2, S3. And very important nerve, we must not forget pudendal nerve. Pudendal nerve innervates the perineum and pudendum, and its root value is S2, S3, S4. Okay, we got the sacral plexus, coccygeal plexus. Here is a coccygeal plexus here. It will provide enococcygeal nerve and pick up sensation and provide nerve supply to the muscles at the perineum, okay, and the coccyx area. Okay, we got the sacral plexus here, and this is the sciatic nerve. What is its root value? L4, L5, S1, S2, S3. This is the pudendal nerve. What is the root value? S2, S3, S4. Okay, we got the sacral plexus. And if we go for down, okay, then we are seeing the femoral branch of genitofemoral nerve, cutaneous innervation, ilioinguinal nerve, the cutaneous innervation, obturator nerve, cutaneous innervation, and this part, cutaneous innervation is done by the femoral nerve, okay, a medial and intermediate cutaneous nerve of the thigh are branches of the femoral nerve, okay, here, and this is the lateral cutaneous nerve of the thigh, L2, L3. If this is compressed, particularly around the inguinal region, we might get the meralgia paresthetica clinical condition. Okay. And dermatome L2, L3, L4, L5, L4, L5, S1. Cutaneous innervation of the leg is very important here. Superficial fibular nerve, root value L4, L5, S1. Superficial fibular nerve pick up sensation from the entire dorsum of the foot, lower part of the lateral aspect of the leg, and most of the foot except the first intertoe area. This yellow area, cutaneous innervation is carried by the deep fibular nerve. Lateral border of the foot, cutaneous sensation is carried by the sural nerve. Medial side of the foot close to the medial malleolus from the ball of the great toe. This is the saphenous nerve. From the first metatarsophalangeal joint over the and around the medial malleolus, medial side of the leg up to medial side of the knee, cutaneous innervation is done by saphenous nerve. There is a branch of the femoral nerve. Root value is L3, L4. Okay. So we got the cutaneous innervation of the front of the thigh and the dorsum of the foot. Okay. This side is getting cutaneous innervation by the lateral cutaneous nerve of the calf here. From here, we get the cutaneous innervation. Okay. So we got the cutaneous innervation posteriorly, very long cutaneous nerve, posterior cutaneous nerve of the thigh. Okay, root value S1, S2, S3. And we'll get lateral cutaneous nerve of the calf here. Okay, so and this is the sural nerve. it is typically a branch of the tibial nerve, and lateral cutaneous branch of the calf. This is a branch of the common fibular nerve. That is the site here. Okay, so we got the cutaneous innervation posteriorly around the ankle joint, around the tendo Achilles. Our root value is S1, partly S2, mostly S1. Okay, we got the S1, S2 is here, S1 is here, mostly S1, partly S2. Okay. Plantar aspect of the foot, we have the nerve, the lateral plantar nerve, medial plantar nerve. They are both motor and sensory. And the dermatome is here in the plantar aspect, L4, L5, and S1, laterally S1. So you got the lumbar plexus, femoral nerve is essential for anterior thigh extension of the knee because it innervates the quadriceps muscle like vastus medialis, vastus lateralis, vastus intermedius, and the rectus femoris muscle. So essential for knee extension. Obturator nerve, also a small contribution of knee extension. I mean, the entire knee extension is done by the femoral nerve, but we have some flexor like that of the sartorius that flexes the knee joint. Not a very strong flexor, weak flexor that is innervated by the femoral nerve. Obturator nerve, medial thigh, and it is essential for adduction. And our muscle innervated by the obturator nerve are the adductor longus, adductor brevis, adductor magnus, the adductor part of adductor magnus, the gracilis, and partly pectineus. Sacral plexus, most important nerve coming out of the sacral plexus is the sciatic nerve. This innervates the hamstring muscles, okay, and also provide cutaneous innervation in the below the knee, okay, and it is the nerve for the hamstring muscle, motor innervation. Two component, tibial nerve and the common fibular nerve, and each of them have the cutaneous innervation like sural nerve from tibial nerve, common fibular nerve is the lateral cutaneous nerve of the calf. Clinical correlation, femoral nerve injury, person cannot extend knee because the quadratus femoris muscle, vastus lateralis, vastus medialis, vastus intermedius, and rectus femoris are paralyzed. Obturator nerve lesion will lead to the condition a person cannot adduct the thigh because of lack of nerve supply to the adductor longus, adductor brevis, adductor part of the adductor magnus, the gracilis, and partly on the pectineus. Common fibular nerve lesion will lead to foot drop. Okay, not only foot drop, and also this person has hard time to elevate the lateral border of the foot. We call it the eversion of the foot will be lost also. Tibial nerve lesion cannot plantar flex because you have very strong muscle in the back of the leg like gastrocnemius soleus, and also the flexor hallucis longus, flexor digitorum longus. They all are innervated by the tibial nerve. So tibial nerve lesion will lead to condition person cannot plantar flex. Okay. Gluteal region, we have muscle gluteus maximus, medius, also minimus. Minimus is deep to the medius. And this is the piriformis muscle. Relationship between piriformis muscle and sciatic nerve. Usually, sciatic nerve comes out of the pelvis below the piriformis, but it may be splitted. One part may go through the piriformis, another part go underneath the piriformis, or one part totally above the piriformis, other part lower part of the piriformis, or the entire nerve, sciatic nerve, perforates the piriformis. Nerve supply of gluteus medius minimus. superior gluteal nerve. Nerve supply of gluteus maximus is inferior gluteal nerve. Nerve supply of piriformis is nerve to the piriformis. Okay. So if a person's gluteus medius or gluteus minimus together is damaged, then there will be positive Trendelenburg sign. Suppose this side is weak. So in that condition, person has hard time to keep the hip in level rather than hip will be like this. So he will turn to the affected side this way. And this is called Tren Trendelenburg sign. So this muscle is unable to hold the hip in straight line with this side like this. So it is sagging down. So the healthy side will sagging down, unhealthy side, the muscle is not working because due to damage to the muscle, no action of the muscle, or nerve supply like superior gluteal nerve is not working, or it has been lesion. Intramuscular injection, we must inject on the upper outer quadrant of the gluteal region to avoid injury to the sciatic nerve and other important nerves. Ideally, it should be injected to the gluteus medius muscle, like this area. Intragluteal intramuscular injection. Okay, muscles, gluteus maximus, chief extensor of the hip joint, gluteus medius minimus, AB duction of the hip joint, Trendelenburg sign cause superior gluteal nerve injury, finding pelvic drops on the opposite side, common in hip surgery, intramuscular injection in the wrong side. So we may have damage to the superior gluteal nerve that will lead to the non-function of gluteus medius, gluteus minimus, also tensor fascia lata. But Trendelenburg sign is mostly related to the gluteus medius non-function. Okay, here are some muscles. We have to know those muscles. Like this is obturator internus muscle here. Okay, and this is the 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 psoas major muscle, iliacus muscle, vastus intermedius muscle. Okay, this is a muscle, the sartorius muscle. This is gluteus maximus muscle. We have to identify the muscle. We must know their origin, insertion, nerve supply, action. Okay, so we got the structures and the muscles. What is this? This is the iliotibial band, and it receives two muscles. One is the tensor fascia lata, another one should be the gluteus maximus. Gluteus maximus around 75% fiber insert to the iliotibial band. Iliotibial band extend from the iliac crest to the Gardis tubercle of the lateral condyle of the tibia. Okay, so we are looking some other muscles like that of the some hamstring. This is a hamstring muscle. Okay, if you go here, this is the biceps femoris muscle, two head. Long head is hamstring, short head is not. Long head innervated by the tibial part of sciatic nerve, short head innervated by the common fibular part of sciatic nerve. Okay, then we'll get the muscle like that of the semimembranosus muscle. Semimembranosus nerve supply, tibial part of sciatic nerve. It flexes knee joint and weakly extend the hip joint. Like this muscle, this is the semitendinosus. It's tendinous insertion, semimembranosus membranous origin, and semitendinosus insert on the pes anserinus, where also sartorius gracilis inserts. Okay, like this muscle, gracilis insert here, and semitendinosus also inserts here. Okay, and we have the sartorius we have seen previously, same site of insertion. We call it pes anserin. Pes, P-E-S, pes, A-N-S-E-R-I-N-E, like the duck foot, three finger, three tendon from three group of muscle innervated by three different nerve supply, like sartorius supplied by the femoral nerve, semitendinosus supplied by the tibial part of sciatic nerve, gracilis innervated or supplied by the obturator nerve. Okay, what is this muscle? This is the adductor magnus. It is an adductor. It is also an hamstring. It has perforation for what? For the passage of perforating branches of the profunda femoris or artery or deep artery of the thigh. This is the adductor hiatus, the gap in the lower part of insertion of the adductor magnus. Through this adductor hiatus, femoral artery goes down, its name will be popliteal artery, and the popliteal vein go above, and that name would be the femoral vein. Okay, we got the adductor muscles, longus, brevis, magnus. Longus innervated by the obturator nerve, brevis innervated by the obturator nerve. Here, the back of the leg, we have very important muscle, the gastrocnemius. Look, they are taking origin from the tibia. I mean, from the femur, upper attachment. That is the upper origin. This is the of the condyle of the tibia. So they flexes the knee joint. Also, in addition to the triceps suri plantar flex, they also these two muscle gastrocnemius as because it is crossing the knee joint, attaching from the tibial condyle, origin from tibial condyle. So they also flexes the knee joint. Gastrocnemius is here. This is the soleus. Soleus takes origin from the fibula plus soleal line, okay, along the medial border of the tibia partly, and soleus gastrocnemius plus the plantaris together forms the triceps suri that inserts to the posterior aspect of the middle third of the calcaneus here. Okay. If we go to the deep muscle, the back of the leg will get the this is the popliteus muscle, essential for unlocking the knee and also flexes the knee, but it has no action on the ankle joint. It's because it does not cross the ankle joint. And we'll get the flexor hallucis longus, flexor digitorum longus, okay, and we'll get the tibialis posterior. Tibialis posterior insert to the tuberosity to navicular bone, but it has slipped to other tarsal, metatarsal bone except first and fifth metatarsal and talus. Nerve supply of all of them should be tibial nerve. Tibial nerve supplies all of them. Okay, so here we are the anterior aspect, where in the anterior aspect we have the quadriceps muscle, rectus femoris muscle, vastus lateralis, vastus medialis. Underneath the rectus femoris, we'll get the vastus intermedius. And what is the nerve supply? Femoral nerve. Hamstring muscle. What are the hamstring muscle? The long head of biceps, the semitendinosus, the semimembranosus. Okay, this is the long head of biceps here. Long head of biceps goes laterally. This is the semimembranosus, semitendinosus, and partly adductor magnus. These are the hamstring muscle innervated by the tibial part of sciatic nerve. Okay, we have some compartment in the leg, anterior compartment. We have the nerve is the femoral nerve in the thigh. Okay, medial compartment of the thigh is the muscle, is the adductor muscle, nerve supply by the obturator nerve. Posterior aspect of the thigh, posterior compartment of the thigh, nerve supply sciatic nerve, the hamstring via the tibial part of sciatic nerve, essential for hip extension. But the hamstring are weak extensor of the hip joint, but very strong flexor of the knee joint. loss of knee extension, femoral nerve lesion, loss of adduction, obturator nerve lesion. Okay, this is femoral triangle area. We have to identify the structure of femoral nerve, root value L2, L3, L4, and it should have cutaneous branches, muscular branches here. One of the cutaneous branch is very long. We call it saphenous nerve. Okay, that goes to the leg, medial aspect, medial border of the foot, close to the even may reach. It goes to the first metatarsophalangeal joint, one of the longest cutaneous nerve. This is a femoral sheath. Femoral sheath is a funnel-like deep fascia sheath for the for its content. Lateral compartment of the femoral sheath. Content is femoral artery. Intermediate compartment. The content is femoral vein. Medial compartment is called femoral canal, almost empty, but it contains the lymph node that pick up lymph from the glans penis or glans clitoris. We call it the gland of Cloquet. Okay, this is the great saphenous vein extending from the medial side of the dorsal venous walk of the foot, passes in front of the medial malleolus along with the saphenous nerve, passes medial to the knee and ascend along the entire medial spectrum of the thigh and opens where? Opens the saphenous vein, opens into the femoral vein in a gap of the deep fascia. We call it saphenous opening with some cribriform points there. Okay, we got that. And the nerve is lateral and lateral to the femoral sheath, then the artery is the femoral artery, then the vein. Empty space is not totally empty, it contains lymphatics, lymph node, gland of Cloquet. And this this is relatively empty. This space is the site for the progression of the femoral hernia, particularly in female postmenopausal obese women. So intestine may go through that like ileum. That may lead to, that is the lead for the femoral hernia. Okay. The intestine may be twisted there. It is possible. Maybe there will be strangulated hernia is possible also. Key point femoral artery is the femoral triangle. Popliteal artery is in the in the knee. Dorsalis pedis artery on the dorsum of the foot. Dorsalis pedis artery is a branch, is a continuation of the anterior tibial artery. And this is inguinal ligament. Here is inguinal ligament. It is formed by the infolding of aponeurosis of external oblique. Okay, so we're studying some of the images here. This is the lateral malleolus. Posterior to the lateral malleolus, we have the tendon of the peroneus longus, also called fibularis longus. Plus, we have the sural nerve goes through that, and also the small saphenous vein will go through that. Right? Okay, this is the fibularis longus tendon. This tendon turns around the lateral border of the foot, goes underneath the cuboid bone, inserts to the medial cuneiform and first metatarsal bone. Nerve supply of the fibularis longus is what? Okay, nerve supply is superficial fibular nerve, also called superficial peroneal nerve. Okay, like peroneus brevis nerve supply, same superficial fibular nerve, but peroneus brevis will insert to the base of the fifth metatarsal bone, over the base of the fifth metatarsal bone. Okay. On the same side, we have the insertion of the little bit medially, insertion of the fibularis tarsus. Here in the back, we call it calf muscle, and we call the soleus as peripheral heart. Okay, because it has some venous spaces. This also has some venous spaces, but mostly the contraction of those venous spaces by the surrounding muscle will lead the venous blood towards the center of our body. Okay, so gastrocnemius soleus, what is their nerve supply? Tibial nerve. Nerve supply of the hamstring is what? Tibial part of sciatic nerve. Okay. Here is the popliteal fossa, diamond-shaped fossa, bounded above and medially by the semimembranosus, semitendinosus, above and laterally by the biceps femoris, okay, below and laterally by the lateral head of gastrocnemius plus plantaris, okay, and also partly by the popliteus. Popliteus mostly forms the floor, okay. We got the medial boundary is formed by the medial head of gastrocnemius. Content from superficial to deep, tibial nerve, popliteal vein, popliteal artery. Popliteal artery is the deepest structure. Okay, this is the sciatic nerve. It divides into two. One is going laterally to the fibula. Okay, laterally to the fibula. Other part going to the go through and through. This is the tibial nerve, popliteal artery and popliteal vein. Above, from superficial to deep, nevia like that of the nerve, tibial nerve vein, popliteal vein, and then femoral artery. On the skin of the superficial fascia, we'll identify two structures, small saphenous vein. It is a tributary of popliteal vein. We'll identify also the sural nerve. It should go along this way. And that is sural nerve is a branch of the tibial nerve. This is a cutaneous nerve, posterior cutaneous nerve of the thigh, very long cutaneous nerve. Okay, it has contribution from S2, S3, S4, okay, that pick up sensation from the entire back of the thigh. That is the posterior cutaneous nerve of the thigh. Here is the tarsal tunnel bounded by the flexor retinaculum. What structure passes underneath the flexor retinaculum? Those are the content of the tarsal tunnel. Like what? Like the tibialis posterior. Then the tendon of the, this is tendon of the tibialis posterior, tendon of the flexor digitorum longus, then artery, posterior tibial artery, posterior tibial vein, and we'll get the tibial nerve and tendon of the flexor hallucis longus. So these are the content, and this is going through the tunnel. We call it tarsal tunnel. Okay, if we have some tinal sign, if we tap on this area, there will be tingling and numbness in the plantar aspect of the foot. These are the muscle on the anterior side of the leg. We are seeing the muscle, the this is the tibialis anterior muscle. This is the extensor hallucis longus, extensor digitorum longus. Okay, so and between these two muscles, we have the deep fibular nerve and the anterior tibial artery. Anterior tibial artery in front of the ankle joint, its name changes into the dorsalis pedis artery. And these two blood vessels, this blood vessel and nerve passes side by side. This is the deep fibular nerve. This is the dorsalis pedis artery, continuation of the anterior tibial artery below the ankle joint. Okay, so we are ready for the tarsal tunnel syndrome. And what is the cause, what structure are within the tarsal tunnel, we must know. If you go posteriorly, we have the muscle, superficial muscle, are like that of the gastrocnemius, soleus, and the plantaris. We have deep muscles like that of the tibialis posterior, then extensor hallucis longus, extensor digitorum longus. They are going through the carpal tunnel. They all have nerve supply, tibial nerve. Okay, let's go to the leg compartment. Very important, anterior compartment. Deep fibular nerve may be compressed. The anterior tibial artery may be compressed both together, and person has hard time to dorsiflex. This lead to foot drop, and this is called anterior compartment syndrome. It may happen due to injury to the leg at the anterior compartment between the shin of the tibia and the muscle like tibialis anterior or the extensor hallucis longus. So Lateral compartment, what is the nerve? Superficial fibular nerve, what is the purpose of this nerve? It innervates two muscles, fibularis longus, fibularis brevis. They evert the foot. Posterior to the leg, our nerve is the tibial nerve and it innervates all the muscles at the back of the leg. Those are essential for plantar flexion. Clinical condition, common fibular nerve injury, fibular neck fracture, foot drop, because person cannot dorsiflex the foot, and sensory loss on the dorsum of the foot. Okay, dorsum of the foot, cutaneous innervation is done mostly by the superficial fibular nerve and partly between the first intertose space. The cutaneous innervation is carried by the deep fibular nerve. So here is the dorsum of the foot. We have to identify the muscle tendons, particularly this is the tibialis anterior, extensor hallucis longus. Between them, what two structure? One is the anterior tibial artery, and another is the deep fibular nerve. Lateral to that, this is the extensor digitorum longus. Okay, what is this nerve? The superficial fibular nerve. Okay, it innervates two muscles, fibularis longus, fibularis brevis. Longus is outside and it is long origin from the upper part of that fibula, brevis from the lower part of the fibula. Both of them innervated by the superficial fibular nerve. There's also cutaneous distribution like this. This is the area, the green area for the cutaneous distribution by the superficial fibular nerve. Lateral border of the foot, the cutaneous innervation is carried by the sural nerve, a branch of the tibial nerve. That nerve passes behind the lateral malleolus. Cutaneous distribution of the first intertose space is the deep fibular nerve, including the nail bed. Okay, regarding the plantar surface, we have the plantar nerve, and we have the medial plantar nerve here. I'm seeing the pink color here. This is also there on the plantar aspect, sort of the foot, medial plantar nerve, and also lateral plantar nerve here. Okay, lateral plantar nerve here, middle plantar nerve here. This is the superficial fibular nerve. This is the deep fibular nerve. This is the saphenous nerve, a branch of the femoral nerve. It pick up sensation from the ball of the great toe going to the medial side of the leg, middle side of the knee, and it is a branch of the saphenous nerve, is a branch of the femoral nerve. Okay. Here we are looking, this is the medial plantar nerve, cutaneous distribution, lateral plantar nerve. Both the medial plantar nerve, lateral plantar nerve are branches of the tibial nerve just below the tarsal tunnel. Okay. So we have the medial plantar nerve, lateral plantar nerve. They may have union here together in their distribution, and clinical condition lead to Morton's neuroma, usually in the third when there is distribution of the digital branches. Okay, and it is a common site of neuroma formation, may be painful between the third third intertose space here, and this is the branch of the medial plantar nerve, a part of the lateral plantar nerve may unite here, and that make the neuroma. Okay, we got that Morton's neuroma that may happen. Here is the arches of the foot: medial longitudinal arch, lateral longitudinal arch, and transverse arch. Arches are essential for smooth movement without injury to the underlying structure, at least partially protecting the underlying structure. And we have the longitudinal arch, medial longitudinal arch, lateral longitudinal arch, transverse arch. Okay. Clinical condition: foot flat, arch collapses. Okay, this is due to damage to the plantar calcaneonavicular ligament, also called spring ligament. Plantar fasciitis is important here. We have the plantar aponeurosis here, particularly in the athletes. They have pain here at the beginning of the plantar aponeurosis, they have pain on the calcaneus. Okay. Here we are looking the muscles here. Okay. So first layer muscle, abductor hallucis, flexor digitorum brevis, abductor digiti minimi. We got the first layer of muscles. Here also same. This is the what is this muscle? This is the flexor digitorum brevis. This is the abductor hallucis. This is the abductor digiti minimi. If you go to the second layer, we'll get the quadratus plantae and lumbrical muscle. Lumbrical muscle taking origin from the tendon of the flexor digitorum longus here and inserts to the expansion of the extensor tendon. It will be inserted there. Okay, like this. Here is the insertion to the dorsal digital expansion of the extensor digitorum longus. Okay, so what is this? Okay, second layer muscle, we got that. Lumbricals, quadratus plantae. You are looking at the third layer. We have the muscle, adductor hallucis, two head here. Also have the flexor hallucis brevis here. Okay. So we got the muscle from the third layer. Fourth layer muscle, mostly interossei muscle here. In third layer, we have another muscle, flexor digiti minimi. Okay. Fourth layer, we have the interossei muscle that is taking origin, that is, those are taking origin from the metatarsal bone, the interossei muscle. We have dorsal interossei muscle. We also palmar interossei muscle. Okay. And we are looking here the quadratus plantae. This is a second layer muscle. Here, abduction, adduction taking place, the axis goes through the second toe. Okay. Axis goes through the second toe. Plantar interossei usually 3. Dorsal interossei are 4. Okay. We got that. Now we are here now. Nerve supply, medial plantar nerve of the foot. It supplies abductor hallucis, flexor digitorum brevis, first lumbrical, and flexor hallucis brevis. Lateral plantar nerve supplies multiple, it like that of the ulnar nerve of the foot. It we have ulnar nerve in our hand. They have a lot of distribution to the intrinsic muscle. Like this, lateral plantar nerve has lot of innervation like abductor digiti minimi, quadratus plantae, second, third, fourth lumbrical, adductor hallucis, flexor digiti minimi brevis, 3 plantar interossei and 4 dorsal interossei. Okay, so let's go to the muscle origin again. Okay, we got that. We have to know this third layer of muscle. One of the muscle is the flexor hallucis brevis, and it is linked with two of the sesamoid bone, small sesamoid bone here. Okay, associated with insertion, tendinous insertion of the flexor hallucis brevis. Okay, flexor hallucis brevis nerve supply is from the medial plantar. And second, third, fourth lumbrical, adductor hallucis, flexor digiti minimi, brevis, 3 plantar interossei, dorsal interossei, all innervated by the lateral plantar. And this muscle is innervated by the medial plantar. Okay, let's get to the review again. Again, foot drop. What is the clinical condition? Common fibular nerve lesion. Yes, sciatic nerve section may also lead to foot drop. Trendelenburg gait, superior gluteal nerve lesion. Person cannot keep the two hip together in the same level. Femoral triangle contains what we discussed: femoral sheath, femoral nerve, And contents of femoral sheath: lateral compartment femoral artery, intermediate compartment femoral vein, most middle compartment is almost empty, it is called femoral canal. Upper part of the femoral canal is called femoral ring. It contains lymph nodes, small lymph node from the glans penis or glans clitoris, called gland of Cloquet. Femoral triangle contains sciatic nerve injury, depends on where is the injury and what are the branches affected, what type of injury. Okay, so a person will hard time to flex the knee, and also flex the ankle joint. Okay, so let's summarize again a little bit. Quadriceps muscle, nerve supply femoral, extend knee. Adductor, nerve supply obturator, adduct thigh. Hamstring muscle, nerve supply, we'll say tibial part of sciatic nerve, extend hip and flexes the knee. This is stronger in hamstring. This is weak extension. Tibialis anterior defibular nerve dorsiflex. Okay, it also help in inversion. Gastrocnemius and inversion eversion take place in the subtalar joint, not in the ankle joint. Ankle joint has dorsiflexion, plantar flexion. Gastrocnemius muscle innervated by tibial nerve, and lesion gastrocnemius soleus plantaris all lead to plantar flex problem. Even the tibialis posterior, the flexor hallucis longus, flexor digitorum longus damage will also weaken the plantar flexion. Okay, so let's go again. The pearl cannot dorsiflex, common fibular nerve lesion, also deep fibular nerve. Okay, defibular nerve independently damaged will also lead to dorsiflex. Defibular nerve is a branch of confibular nerve. Cannot extend, but in case of confibular nerve lesion, the fibularis longus, fibularis brevis will be also non-functional. So person cannot evert the foot. Okay, in case of common fibular nerve lesion. But defibular nerve lesion, they can evert the foot, but there will be foot drop in case of isolated defibular nerve lesion. Okay, cannot adduct thigh obturator, pelvic drop, supraglutial nerve lesion, loss of plantar flexion, tibial nerve lesion. Okay, now let's solve some question. A 28-year-old man presents after a fall. He has a fracture the neck of the fibula. On examination, he cannot dorsiflex his foot, walks with a high stepping gait. Sensation is lost over the dorsum of the foot, which nerve is most likely injured. So, neck of the fibula, our nerve is the common fibula. The common fibular nerve winds around the neck of the fibula, highly vulnerable. Injury causes loss of dorsiflexion, foot drop, loss of eversion, sensory loss over the dorsum of the foot. Okay. Then exam part, fibular neck fracture, common fibular nerve injury, foot drop. Question number 2. A patient undergoes a catheterization procedure via the femoral artery. Post-procedure, he developed weakness in the knee extension and decreased patellar reflex. Which structure is most likely affected? We have to know the content of femoral triangle. Okay, our femoral artery or femoral vein may be used for catheterization. The femoral nerve is just lateral to the femoral artery, and if it is damaged, femoral nerve is damaged, what will happen? Quadriceps muscle cannot work, so person cannot extend the knee. Okay, and there will be loss of patellar reflex. That is the answer. So answer should be what? The femoral nerve lesion. Femoral nerve lies lateral to the femoral artery and femoral triangle. Injury leads to weak knee extension because of non-function of quadriceps femoris that include rectus femoris, vastus medialis, vastus lateralis, vastus intermedius. Patellar reflex lost, L3, L4, L2 may be partly lost. Example, loss of knee extension, knee jerk equal to femoral nerve lesion. Okay, here a 65-year-old woman presents with pelvic instability. When she stands on her right leg, her pelvis drops on the left side. Which nerve is most likely damaged? We have gone through the Trendelenburg sign. So the nerve lesion is the superior gluteal nerve. Explanation: superior gluteal nerve supplies gluteus medius, minimus, also tensor fascia lata. But for the Trendelenburg sign, most important muscle is the gluteus medius. This stabilizes the pelvis during weakness. Injury lead to positive Trendelenburg gait. That means one of the hip will go down. Okay. Pelvis drops on contralateral side. A patient presents with difficulty extending the hip and flexing the knee following a traumatic injury, which nerve is most likely involved. So the hamstring muscles. Answer should be sciatic nerve. Explanation: sciatic nerve supplies hamstring. What are the hamstring? Semimembranous, semitendinous, hamstring part of the adductor magnus, and the long head of biceps femoris. Their function is what? They are weak extensor of the hip, strong flexor of the knee. So our answer should be the sciatic. Okay. Question number 5. A mass compresses structure within the popliteal fossa. The patient is unable to plantar flex the foot and cannot stand on tiptoe. Which nerve is affected? Standing on tiptoe needs plantar flexion, strong muscle like that of the soleus, gastrocnemius, and maybe very little by plantaris. So our nerve supply is the tibial nerve at the back of the leg. It innervates all the muscles in the posterior leg. It functions plantar flexion, toe flexion. Examination: Pearl cannot stand on toe due to tibial nerve lesion, and tibial nerve is a branch of the sciatic nerve at the upper part of the popliteal fossa near the apex of the popliteal fossa. Okay. Question number 6. A soccer player presents with inability to adduct the thigh during a groin injury. Which nerve is mostly likely injured? Okay, femoral nerve, obturator nerve, sciatic nerve, tibial nerve, superior gluteal nerve. We have problem in in adduction, that means adductor muscles, and the adductor muscles are innervated by the obturator nerve. So our answer should be obturator nerve supplies the medial thigh adductors. Injury lead to loss of thigh adduction. Example: groin injury plus adduction loss. That means obturator nerve lesion. Okay. Question number 7. We have got 6. Okay, we have got the 6. Question number 7. A patient develops compartment syndrome of the anterior leg. He cannot dorsiflex his foot. Which muscle is most likely affected? Most likely affected in tibial shin or anterior compartment syndrome is the tibialis anterior. Primary dorsiflexion of the foot located in anterior compartment innervated by deep fibular nerve. Example: foot drop, that means tibialis anterior dysfunction. Question number 8. A patient has difficulty rising from seated position and climbing stairs. Which muscle is primarily affected? So for standing from sitting from the chair, we need the extension of the hip joint at the upper part, lower part certainly the knee joint. So upper, we have the most important muscle is the gluteus maximus, essential for a person to sit from a chair to stand up. Also, he need to extend the knee, but we'll give emphasis for this patient on the gluteus maximus, innervated by inferior gluteal nerve, function, powerful hip extension, rising from sitting, example, difficulty climbing stair, gluteus maximus problem. So where we are now? Here, the question number 9, a patient presents with loss of sensation on the lateral sole of the foot and inability to abduct the toes. Which nerve is affected? So for abduction, adduction of the foot, okay, we have the interossei muscles. Those both both the dorsal interossei and plantar interossei innervated by the lateral plantar nerve. Okay, we got the okay. So what is this question? Loss of sensation on the lateral side of the sole and of the foot and inability to abduct the toes, our answer should be the lateral plantar nerve. Answer should be lateral plantar nerve. It behaves like ulnar nerve in the hand. Ulnar nerve also help in abduction, adduction, like that. Okay. So for abduction, adduction of the foot, particularly the sole muscle, plantar interossei, and also dorsal muscle, dorsal interossei, innervated by the lateral plantar. Question number 10. During surgery, a structure within the femoral triangle is accidentally ligated. Patient retains sensation but develops ischemia of the lower limb. Which structure is most likely ligated? Femoral triangle. What structure is ligated? Patient has no problem in sensation but develop ischemia of the limb. Major artery supply the lower limb is ligated ischemia. So we have the structure. What is the structure is ligated? The femoral artery here. That is the artery that supplies the thigh limb. Okay, patient retains sensation but develops ischemia of the lower limb. That is the femoral artery. Femoral artery is very important artery. It goes through the adductor hiatus, become popliteal artery, and it will be splitted into anterior tibial artery, posterior tibial artery. Anterior tibial artery will be the dorsal spadius artery. Posterior tibial artery under the flexor retinaculum in the tarsal tunnel will be lateral plantar artery and medial plantar artery. So here our answer should be the femoral artery, the major artery in the lower limb that is very essential to provide blood supply to the entire lower limb. Our answer also it has a branch like profunda femoris artery, perforating branches that supplies the thigh. So back of the leg, front of the leg, dorsum of the foot, plantar aspect of the foot, everything are coming from the branches of the femoral artery. Answer should be femoral artery. C is the answer. Okay. Now we have some injuries. Anterior cruciate ligament injury. There is a knee injury, injury to the knee. What is the sign? Anterior drawer sign. You can pull the tibia anteriorly. Posterior cruciate ligament injury to the knee joint. Again, posterior drawer sign. You can push back the tibia over the femur. Unhappy triad. It is a problem with three component like that of the anterior cruciate ligament injury, medial meniscus injury, tibial collateral ligament injury. Fracture neck of the femur, important to us, and it may lead to necrosis because blood supply to the neck of the femur is mostly done by medial circumflex femoral artery, partly lateral circumflex femoral artery. These are branches of the profunda femoris artery. So fracture neck of the femur will have some clinical manifestation, shortening of the limb, it will be abducted, laterally rotated. Okay. This is the fracture neck of the femur. We must know the blood supply, mostly medial circumflex femoral artery branch of the profunda femoris artery. Okay. And we may have dislocation of the hip joint. Femoral head may go posteriorly. It may damage the sciatic nerve. And in case of posterior dislocation, that is most common of the hip joint, there will be shortening of the leg, but leg will be adducted and medially rotated. Okay, so posterior dislocation, nerve damage is the sciatic nerve. Again, shortening of the lower limb, affected side, but it will be adducted and medially rotated. In ankle sprain, what happens? This is a very strong inversion plus plantar flexion condition that may damage the anterior talofibular ligament. Most commonly injured ligament in ankle sprain, anterior talofibular ligament, because this is the weakest ligament of the lateral ankle. Most vulnerable injury, inversion injury, foot turns inward, plantar flexion, toes pointed down, okay, and the ligament torn is the ATFL, anterior talofibular ligament. Spring ligament is present on the under surface of the foot, actually, on the sole. Also called plantar calcaneonavicular ligament injury leads to pes planus, collapsed arch. Spring ligament problem. Okay, how about the deltoid ligament that is present on the ankle joint medially and ankle joint as well as the tarsal bones, the deltoid ligament, it may be damaged in severe eversion. It is a strong ligament, deltoid ligament. So usually it is not torn, but may be possible, may be damaged. Okay. Depending on the impact of injury and the amount of injury, type of fall. So inversion injury leads to damage or strong plantar flexion, with inversion lead to ATFL damage. Eversion injury may lead to damage to the deltoid ligament, that is rare. And ligament is stronger. But ATFL is very weak ligament. And that's all about the USMLE review on the lower limb anatomy. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.